Okay, good morning, everyone. So today we are going to talk about appendicitis. Now, in the last class, before the semester is ended, the last class of surgery, I already talked about this, but that was a bit of long time ago. So it's a good time for us to revise it again. Okay, whatever we have discussed, because this is absolutely important topic from the exam point of view and from the clinical point of view also. Whenever you go to any surgical hospital, any surgical ward, any emergency room of the hospital, you will see a lot of cases of appendicitis. So a medical student, okay, should be aware of how appendicitis present, how to diagnose, and how to treat. Now let's start with anatomy of appendix. Now you all know appendix is also known as vermiform appendix because of its shape. Okay, it looks like a worm. That's why the name vermiform is given. So vermiform appendix, or simply the appendix, uh, please mute yourself, is present in the right iliac fossa, isn't it? It is present in the right iliac fossa. Now, uh, it start to develop from the 6th week of embryological development at the base of the cecum, near the junction of ileum and cecum. We call that ileocecal junction. Now, accordingly, it has got different position. Now, one important point here, the base of the appendix is always constant, okay, or fixed, whereas the apex or tip, rather than apex, we call it tip of the appendix varies in different position. It differ according to the person. So what information you learn here? The surgeon has to know these things. Whenever incision is given in the right iliac fossa, whenever we enter into the peritoneal cavity, sometimes the appendix is right there in front of your eye. Sometimes you need to find or search for the tip of the appendix. But one common clue will be there. At the base of the appendix, there is convergence of three tinea coli. Okay, tinea coli, you all know tinea coli are some of the special features of large intestine. Appendix is a part of the large intestine. So all those three tinea coli will converge at the base of the appendix. That's how the surgeon knows, yes, this is the base. Now, after finding the base, apex will be relatively easier. Now see this picture. These are the different positions of the appendix. Retrocolic, okay, or retrocecal we say, is the commonest one. This is also known as a 12 o'clock position according to the clock. Now this is paracolic. This is pre-ileal and post-ileal. We call it 2 o'clock position. This is promontoric. This promontoric is the term we got from the sacral promontory. Okay, sacral promontory. Then pelvic appendix. So these are the different positions. This is according to the clock. Let's move on. Another picture is also showing the same thing. See that retrocecal appendix is the commonest one according to the position. Okay, this percentage may differ if you follow different textbook. Okay, but just remember which is the most common one. Retrocecal followed by pelvic appendix. See this, almost 21% pelvic, 74% retrocecal. Now, mesoappendix is the mesentery which suspend the appendix from the terminal ileum. Just like jejunum and ileum are suspended by the mesentery, okay, appendix is suspended by mesoappendix. This is the fold of the peritoneum. This mesoappendix contains the appendicular artery. Now, we all know our GI tract, okay, or the main part of the gut or GI tract, or you can say alimentary canal, is divided into three major parts according to the embryological development. Okay, these are called foregut, midgut, and hindgut. Now, can anybody tell me what is the blood supply of the foregut? Yes. What is the blood supply of the foregut? Anyone?
Sir, by the superior mesenteric artery.
Okay. Any other answer? Okay, let me hear some more. Yes.
Inferior mesenteric artery, sir.
Okay. Any other student? Any other? Okay, fine. Now see, listen here. Okay. Now listen. Okay. According to the embryological development, the gastrointestinal tract is divided into three parts. That is called foregut, midgut, and hindgut. Very easy. Foregut, midgut, and hindgut. The artery which is responsible for the blood supply of foregut is called celiac trunk. Okay, celiac trunk. Remember, the celiac trunk is very near to the stomach. Okay, that part. And the celiac trunk comes out from the abdominal aorta. The artery responsible for midgut is superior mesenteric artery, and the artery responsible for hindgut is called inferior mesenteric artery. So never forget this. Okay, you have done this before, I'm sure about it. Celiac trunk, superior mesenteric artery, inferior mesenteric artery. These are the major arteries for the different type parts of the alimentary canal or GI tract. Now let's focus completely on the midgut area, because that's what we are talking right now. So the artery is superior mesenteric artery, which comes out from the abdominal aorta. It has got one important branch, which is called ileocolic artery, and that ileocolic artery gives rise to appendicular artery. So that's how the appendix is supplied. And one important point here is, before the surgeon removes the appendix, this appendicular artery has to be secured. Okay, secured means it has to be identified, it has to be tied properly, and then only it should be cut. Otherwise, there will be severe hemorrhage. Now, let's go to the histology of appendix. So, just like any other parts of the GI tract, there are four layers. Mucosa, submucosa, muscle layer, and serosa. Okay, so this muscle layer have got two components, circular and longitudinal. Circular is inside, longitudinal is outside. It's quite easy. Now, I already talked about how to identify the appendix during surgery. During internship or after you do your MBBS. Whenever you go to hospital, whenever you are in the operation room to help the surgeon, and you are helping the appendectomy operation or surgery, please remember this fact or this point, how to identify appendix there. Okay, you have to follow the three bands of the tinea coli, which converge on the base of the appendix. Sometimes appendix is right there in front of your eye, you don't need to even to do that. Now, what is the function of the appendix? Anybody? What is the function? Is it useful for us?
It's an immunological organ.
Immunity.
Good answer. This is an immunological organ, but the amount of immunological function it has is very minimal, so we can sacrifice it easily. Okay, so your answer is absolutely correct, though different textbook mention this as a vestigial organ. Okay, still it has some role in immunity. It is very nicely written here. It is secreting IgA antibody, and that IgA antibody is also known as secretory type of antibody. Having said that, the function which is contributed by appendix is very minimal. So if any problem occurs, we can sacrifice it or we can remove it easily.
Sir?
Yes?
I have read somewhere that the appendix stores some bacteria as well. Is it true, sir?
Of course, appendix, just like any other parts of the large intestine, it has normal commensals, okay? Many normal commensals are there.
Okay, sir. Okay, thank you.
Yeah, in the lumen of large intestine, there are lots of normal flora. We have studied that already, but they don't cause infection there. We'll talk about that later on in pathophysiology. But when there is a breaching of the defense system, then the same bacteria may cause the problem. Now, what is the length of the appendix? See this, it is highly variable. It ranges from 2 to 20 centimeter, but normally on average, it is around 6 to 8 centimeter. So in some of the people, it is as long as 20 centimeter. That is very long appendix. The luminal capacity is less than 1 ml and it secretes some of the fluid, okay, and that fluid should be constantly drained. If the fluid drainage is obstructed, then there is distension of the lumen of appendix, and that will lead to acute appendicitis. Okay, let's move further. So this is such an important point, so that it is highlighted again here. See this, whenever we are doing appendectomy surgery, after we open the abdomen, after we open the peritoneal cavity, after we identify the cecum, we can easily find the appendix by following the 3 tinea coli until they converge at the base of the appendix. This is the best way, and you should never forget it. Now, how common it is? You have heard about appendicitis everywhere. Okay, you are a medical student. Whenever you go to hospital, in your senior talk, yes, we did appendectomy, this many appendectomy today or this week, something like that. So this case is very, very common. This is one of the most common case of acute abdomen. The incidence is highest in early adulthood at the peak of lymphoid tissue growth. It can occur even in children. Now, remember, in case of children or in early adulthood, this is the time for lymphoid overgrowth. And this appendix has got lymphoid follicle. So whenever those lymphoid follicle are a bit of bigger in size, they can obstruct the lumen of the appendix, so that whatever fluid is there, it collects and lead to distension of the appendix. And this is very early phase of appendicitis. The second peak occurs in the elderly. And regarding the male to female ratio, see, it is almost the same. Okay, males are slightly more commoner to have appendicitis than female, 1.3 to 1, but it is not of a bigger concern here. Now, let's go to the more important part of this class, that is pathophysiology. Every student should understand how appendicitis occurs. Okay, this is a common question which is asked to you by your patient. They say, "Doctor, how I got appendicitis?" And sometimes they may ask, what is the chance that my other family member may also get the disease? So if you know how the disease occurs, you can exactly explain it. Now, see this? The probable sequence of event in acute appendicitis are, first, there occurs obstruction of the lumen. Already talked about. This is the first step. Now, how it happens? In young patient, it occurs by lymphoid tissue hyperplasia. Okay, lymphoid tissue hyperplasia, which occurs in that age group. But in older patient or in young individual, ficholith is an increasingly common cause of obstruction. Now, this ficholith, okay, let's analyze this term. Lith is a stone. Okay, fico is a fecal matter or a stool. So this is some type of very hard stool, okay, which almost presents like a stone. You understand, like that? Whenever that hard constipated stool is present in the lumen of the appendix, definitely it is going to produce the obstruction. Now, after that, what happens? There will be distension and increased intraluminal pressure buildup, because it is already obstructed. The mucosa of the appendix is continuously secreting mucus. That mucus cannot be drained outside, so it will be collected there, which leads to distension. Okay. Now remember, if any of the normal physiological process is disrupted, there will be migration of bacteria there. Okay. So this will happen, and this will even happen more later on when there is ischemia development. Let's move on. Another step in the pathophysiology is venous congestion. This is very easy to understand. What is happening to the appendix? It is getting distended. Okay, it is having a lot of pressure inside. So that intraluminal pressure, okay, eventually leads to pressure in the capillary and the vein. So there will be obstruction of the venous drainage that will lead to venous congestion. Later on, the pressure is so high that even the arteriolar blood flow there will be obstructed. and that can lead to ischemia. You see this? Okay, let me underline this. This is a very important step to understand. See this. This lead to ischemia. In the beginning, ischemia doesn't occur. In the beginning, there is venous congestion. Later on, there will be ischemia. This ischemia will lead to necrosis, and that can even lead to further bacterial invasion. And finally, okay, this bacterial invasion leads to inflammation or infection, and this ischemia can even lead to perforation. Okay, because ischemia lead to necrosis. Necrosed tissue are weak; they can easily perforate. So whatever microorganisms, whatever the features of infection is there inside the appendix, after perforation, where it go now? Yes, after it is perforated, where these materials will leak into?
Abdominal cavity.
The abdominal cavity.
Absolutely, into the peritoneal cavity or abdominal cavity. Now that's the danger. That's the danger for the patient. If we diagnose appendicitis quite early, before it is ruptured or perforated, treatment is so easy. You just remove that appendix. Everything is fine, no problem for the patient. But if it is already ruptured, if peritonitis has already occurred, treatment will be complicated, and there is a chance of mortality as well. That's why timely diagnosis has to be done. Okay, let's move on. Now, to summarize this pathophysiology, this is an excellent slide. Okay, but the points you have already understood. Now let's go through this once again. In the beginning, there is obstruction of the appendix lumen. In the younger individual, it may be because of the lymphoid hyperplasia, and later on, it may be because of the ficcolith. Sometimes it may be because of worms also. Some worms are present in the intestine. Those worms may migrate into the appendix lumen, and they may also cause the obstruction. There are different cases have been reported. After that, there is buildup of the mucus, which leads to distension. Okay, that distension leads to increased appendicular lumen pressure. Now, in the beginning, there is engorgement of the vein. Okay, this is called congestion. Later on, it will lead to ischemia. Okay, it will lead to ischemia because of decreased blood flow to the appendix. Ischemia lead to hypoxia. That will lead to ulceration or even frank necrosis of the wall of the appendix. Whatever microorganisms are there as a normal commensal, they can invade there. That leads to inflammation and infection, which we call as appendicitis. Now, this is another picture which is showing the same thing. Okay, so we can go a little bit quickly now. This is a case of early appendicitis. Okay, early appendicitis. And in case of early appendicitis, the patient will have pain around the umbilical area, because during this stage, the appendix is only distended. This is the pain of distension of the appendix. You always remember this. This is a visceral pain. This is not a parietal pain. Only after the parietal peritoneum is involved, which is lying over the appendix, then the pain will be shifted towards the right iliac fossa. This will happen a bit later on, not in the beginning. And if this process continue, then finally there will be perforation of the appendix, and this will lead to peritonitis. Now, let's go to a very important part of this lecture, how the patient present to the hospital. What are the common symptoms? And during the examination, what signs you get? Now, see this. The common symptom, okay, from the patient side would be pain. This is the commonest. Where? Okay, the pain starts from periumbilical area. So you have to take a very good history here. You have to exactly ask, what is the first place or site where you felt the pain? And patients say it is from the umbilical area. They will show near to the umbilical area or around the umbilical area. Okay. After a few hours of that type of pain, the pain would be shifted to the right iliac fossa. where there is location of the appendix. This is all about the relation of visceral pain versus parietal pain. Periumbilical pain is called visceral pain, which occurs early, and pain in the right iliac fossa is called parietal pain. This occurs late when parietal peritoneum is involved. Now, this is called migration of the pain. At the same time, you have to take the history of nausea, vomiting, and anorexia, which is also very common. And patient may also have mild fever. Fever is not that high grade, just mild type of fever in the beginning. But if the patient ignore, if they do not come to the hospital in time, if appendix is already ruptured or burst, leading to peritonitis, the fever may be high grade as well. Now, as a doctor, you need to examine that patient, isn't it? So what are the signs you get? See here. Now, first is there is localized tenderness. There are 2 points here. One is a direct or localized tenderness. Another is rebound tenderness. Now, let me explain this nicely here. Please pay attention. Whenever we press at the McBurney's point is having base of the appendix. And you all know where is the McBurney's point. Yes, let me ask this question to some of the students. Where is McBurney's point?
Interior two-thirds from the umbilical and one-third from the iliac
Right
septum.
iliac, lower right iliac fossa, two-third of the umbilicus. It is
Exactly.
maximum tenderness.
So I am 100% sure everybody knows that, okay, because we have already done this. So regarding the McBurney's point, you need to know 2 landmarks. Those 2 landmarks are umbilicus and ASIS, anterior superior iliac spine. Anterior superior iliac spine. Now, medial 2/3 and lateral 1/3. Okay, you need to remember like that. Medial 2/3 and lateral 1/3. That exact boundary between these 2 lines is the base of the appendix or McBurney's point. And in case of acute appendicitis, it is the site of maximum tenderness. Now there are 2 types of tenderness. One is called direct, direct localized tenderness. Now, what does that mean? Whenever I press that area, the patient feels pain because it is inflamed. And another one, when I remove my finger, when I remove my hand from that site after pressing, the peritoneum will jump back to its original position. And during that time, the pain is even more, because there is sudden stretching of the peritoneum. So this is known as rebound tenderness. So always remember this. So rebound tenderness is even more important in this case. But direct tenderness is also important. Okay, I'm not saying that, but rebound tenderness has to be elicited. Now, another one is leukocytosis. Leukocytosis. Now, leukocytosis is raise in WBC count. This is one of the common feature of appendicitis because of bacterial infection which is occurring there. Another is Robson sign. This leukocytosis, though actually speaking, it is a lab feature, but it is included as one of the signs because it really helps us in the diagnosis. Now, what is Robson sign? Robson sign means when we palpate or press on the left iliac fossa, left lower quadrant means left iliac fossa, the patient feels pain in the right iliac fossa. Now, one question must come in your mind. What is the relation? Why that is happening? Why the patient is feeling pain in right iliac fossa when I press in the left iliac fossa? Any answer? Anyone?
Sir, when we press on the right side, the colon impinges on the inflamed appendix. That's why it also produces pain.
Very good. Good answer. Anybody else? Yeah, sure.
Yes, sir. Basically, sir, the colon puts pressure when we, sir, when you press on it, sir, it's put pressure on, sir, where the inflammation is at the sir, the appendix region. So, sir, that's why there is that pain shifting at that point.
Exactly. Both of them are answer the same thing, and I'm sure every student know this. Remember, this colon is a continuous structure. The colon is a continuous structure, and appendix is a part of that. So what we are pressing in the right iliac fossa, left iliac fossa, sigmoid colon is there. Now there's also a bit of gas present inside the colon. So there will movement of the colon along with the movement of the gas that will give slight pressure to the inflamed appendix in the right iliac fossa, and that will lead to pain in the patient. So this is known as a Robsing sign. Another one is a ilio-Schwarz sign, or simply Schwarz sign. In some of the textbook, it is written as a Schwarz sign only. Now, what is that? Schwarz sign means this is, in connection with Schwarz major muscle. The Schwarz major muscle is present at that site in the right iliac fossa region, and it is inserted, into the lesser trochanter of femur. This is one of the major muscle which is related with the flexion of the hip joint. Now see this, so having known the function, it is very easy to elicit this sign. If we extend, the right hip, because appendix is present on the right side, that's what we are doing. If we are extending the right hip, this Schwarz major muscle or ilio-Schwarz muscle will also be stretched. And if appendix is present on the surface, which is seen in retrocecal appendix, then patient will complain pain. When you flex the hip, there will be no stretching of ilio-Schwarz muscle, so there will be no pain. We need to extend the hip to elicit the pain. And by the way, if we flex the thigh or the hip, pain will be relieved because the muscle is no more stretched. So this is the Schwarz sign. Another one is a obturator sign. This obturator sign is positive in case of pelvic appendicitis. This is the second most common position of the appendix. You already know that. So pelvic pain occurs on internal rotation of the right thigh. That is a function of obturator internus muscle. So that's why the pain occurs there. Now these are the different signs which are seen in appendicitis. Let's move on. Now see that that is the McBurney's point. But even before I show this, all of my students already know because this was already discussed detailed before. Now see here, this is umbilicus, this is ASIS. We have to 2/3 medially and 1/3 laterally. Medially means towards the umbilicus. This distance is 2/3 of the total. This is 1/3 of the total, and the boundary between them is the McBurney's point. Now you can do this slide on your own. But a very important point is written here though. The pain in case of acute appendicitis are of two types. In the beginning, it is a vague type of pain. It is periumbilical pain. That is visceral type of pain. Visceral. And this visceral pain usually occurs because of distension of the appendicular lumen. Later on, the pain will be shifted to the right iliac fossa, and this is because of irritation of the parietal peritoneum, and this is known as somatic pain. Now, whenever we assess appendicitis, from our side as a doctor, these are the important points regarding the symptoms and sign of the patient. Pain, already discussed, anorexia, nausea, and vomiting. There is increased temperature. Though it is slight, it is very important one. You have to always take the temperature in the patient. Then if we do leukocytosis or WBC count, there will be leukocytosis like 15,000 to 20,000, but it may be lesser than that. You all know what is a normal WBC count. What is normal?
Sir, 11,000 to 14,000 mainly.
11,000.
Yeah, normal is up to 11,000, right? Yes, up to 11,000. Anything more than that will be counted as a positive feature here. It should not be 15 to 20,000 all the time. So that is more important. And we definitely elicit these signs in the patient. Always remember this: Robsing sign, rebound tenderness, okay, Schwarz sign, and obturator sign. These are the important ones. Now, what are the differential diagnosis of appendicitis? Another important question which is asked to the student. All abdominal pain is not appendicitis. Remember that there are so many other conditions which may look like appendicitis. These are known as a differential diagnosis. So there are certain GI conditions and certain genitourinary conditions, and according to the age and sex of the patient, the differential diagnosis may vary. So let's talk about that now. Among the gastrointestinal condition, gastroenteritis. So this gastroenteritis, is also known as diarrhea. This is a medical term for diarrhea, and vomiting usually occurs. Okay, gastroenteritis. Usually there is crampy type of abdominal pain. So sometimes it may be confused with appendicitis in the early case. Mesenteric adenitis is very common in children in pediatric age group. Inflammation of the mesenteric group of lymph nodes. Michel's diverticulum. This is the embryological structure. Okay, it may be present in 2% of the population. Okay, 2% of the population. It may cause pain even without inflammation because of the gastric, ectopic cells which are present there. These are the parietal cell. They may secrete hydrochloric acid that may burn the mucosa there, and almost peptic ulcer like pain may be felt there. Okay, and another way is inflammation itself. Intussusception. Intussusception is a telescoping of proximal segment into the distal one. This is an excellent way to remember. Telescoping of a proximal segment into the distal one. And there are different ways of presentation. One is intestinal obstruction. Second is ischemia or gangrene of the bowel. But that takes time. That takes a few hours to develop. So as soon as the features of intestinal obstructions are there in a child, we should always suspect intussusception and try to diagnose it in time. Typhoid fever. Typhoid fever. What is the causative agent of typhoid fever?
Salmonella
typhi.
Salmonella typhi.
Excellent. This is a medical illness which is caused by a bacteria known as Salmonella typhi, and this is entering in our body through the fecal-oral route. That means contaminated food and water. Okay, and typhoid fever, the exact location of typhoid fever in the intestine is Pear's patches, and Pear's patches are present in the ileum. Remember, it is very near to the appendix, and if that Pear's patches inflammation is perforated, it almost looks like appendicitis. That's why it is included here. And primary peritonitis, definitely. Okay, this is inflammation of the peritoneum. Now, regarding the genitourinary conditions, ectopic pregnancy in case of female, sometimes we are quite confused because that fallopian tube is present on both iliac fossa, right iliac fossa as well as left. And ectopic pregnancy usually occurs in the fallopian tube. Okay, so the signs and symptoms may match there. This is a very serious condition, and I'll take a separate class in gynecology regarding ectopic pregnancy. PID, okay, pelvic inflammatory disease in case of female, the signs and symptoms may match. Disease of the ovary, like ovarian torsion, ovarian cyst, and ovarian tumor. Urinary tract infection or pyelonephritis, not cystitis, okay? It has to be pyelonephritis because it causes pain and fever. And ureteric stone or kidney stone. These are some of the non-differential diagnoses. Now, there is one important point written here. Yersinia enterocolitica is a type of bacteria. It belongs to Yersinia family, just like Yersinia pestis, which is a causative agent of plague. But this is not the causative agent of plague, it causes GI infection. That's why the term enterolytica. Okay, this is a gram-negative type of bacilli. Now, what happens? This bacteria is usually present in the some type of meat which is not cooked properly, like a pork meat or some other contaminated meat or food or water. And if somebody is consuming that type of contaminated food, then there is a chance of a mesenteric adenitis by this particular bacteria, which almost presents like appendicitis. So remember, Yersinia enterocolitica, and it may present as diarrhea. Okay, that diarrhea may last for a few days. Along with diarrhea, there will be abdominal pain definitely, and then there is mild fever also. But later on, what happens? It will get resolved by itself, even if you do not treat it. But if you provide some treatment like doxycycline, treatment will be faster. We are towards the end of this session now. Now see this. These are the differential diagnosis of acute appendicitis according to the age. In case of children, these are the common differential diagnosis. In case of adult, these are the one. Now see this. In children, okay, most of the point we have already covered. Gastroenteritis, mesenteric adenitis, Michel's diverticulitis, intersusception. But there is one point which I like to highlight here, that is Hanoch, okay, Schonlein purpura. We call it HSP. This HSP is very common in children or pediatric age group. It is considered as an immunological disease, okay, or you can also call it autoimmune disease. There are 4 things which commonly occurs here. One is rash. Second is involvement of the GI tract. Third, involvement of the kidney. And fourth, involvement of the joint. Never forget it. Rash, GI involvement, okay, joint involvement, and kidney involvement. And if all these 4 features are there, then without any doubt, we can easily diagnose this is a case of HSP. Okay. So we will talk about this more when some appropriate time and the appropriate lectures comes again. Lobar pneumonia, this causes a pain, especially the lower lobe, if they are inflamed, if they are infected. Talking about the differential diagnosis of acute appendicitis. According to the age, the differential diagnosis may vary. Now see that in the children, we talked about, before the break, gastroenteritis, mesenteric adenitis, Michel's diverticulum or diverticulitis, intersusception, HSP, and lobar pneumonia are the common one. Among them, a favorite question from the examiner's point of view is HSP, and there are a constellation of 4 features together. So let me write those 4 features so that student can remember it for a relatively longer time. Okay, now see here. The first is rash. Regarding these rashes, these are palpable type of rash. Palpable means they are vasculitic rash. Please mute yourself. These are vasculitic rash, and they are mainly present on the buttock area, buttock as well as lower limbs. I'm only providing you the very important points that you can remember this. Okay, so these are the important features of the rash. These rashes are present in 100% of the cases. Without rash, my diagnosis of HSP is in doubt. The second is GI involvement. GI involvement. Okay, GI involvement. There may be blood in the stool. Sometimes the child may present as intersusception also. So blood in the stool, abdominal pain, and intersusception. These are the common features of GI involvement. Third is the renal involvement. Renal involvement. There may be glomerulonephritis. There may be proteinuria. There may be hematuria in case of kidney involvement. Sometimes the patient may present as a renal failure also. And the last one is arthritis, a joint involvement. Okay, arthritis or joint involvement. So these are the 4 features. Please do not forget about it. Now let's go to the adult. What are the common differential diagnosis? Though we have already listed them. Okay, regional enteritis. Okay, regional enteritis, also sometimes known as Crohn's disease, ureteric colic. There's a stone in the ureter. Perforated peptic ulcer. It also causes peritonitis. That's why it is considered. Torsion of the testes. Okay, it is also having referred pain there. Pancreatitis, another cause of severe abdominal pain, and sometimes even rectus sheath hematoma. This is present in the superficial part of the abdominal wall. Let's move on. Now, in case of female, what are the differential diagnoses? See here, in adult female, Mittel's merge pain may be considered as one of the differential diagnoses. Now, anybody tell me what is Mittel's merge pain? What is this?
Pain on ovulation.
Sir, it is ovulation pain, and sir, it is also known as the mid-cycle pains because sir, it comes in the mid of the menstruation cycle.
Absolutely, both of them are absolutely correct. This is, mid-cycle pain or ovulation pain. When a lady ovulates, okay, after the menarche occurs, she ovulates every month. Okay, if there is not any other abnormality during that time, there may be slight pain, and that may be confused with early appendicitis pain. Pelvic inflammatory disease or PID, already talked about. Pyelonephritis, ectopic pregnancy, torsion or rupture of the ovarian cyst, and endometriosis. This is a very interesting condition which I will discuss in detail in gynecology. This is the presence of ectopic endometrial tissue, okay, outside. Ectopic is the term for outside, you already know. Normally it is present in the endometrial cavity or inside the uterus only, but in this situation, the endometrial tissue is present in the fallopian tube. It may be present in the ovary. It may be present in somewhere else also. This condition is known as endometriosis. Now, in the elderly population, these are the differential diagnoses of appendicitis. Diverticulitis. Okay, this is the inflammation of diverticulum, which is very common in sigmoid colon. Intestinal obstruction, colonic carcinoma. Okay, colonic carcinoma, again left-sided is more common, though appendix is present on the right side, but it may cause the vague abdominal pain by causing bowel obstruction, so it can be considered. Torsion appendix epiploica. This appendices epiploica is another important hallmark of the large intestine. These are the small pad of the fat which are present there. If that pad of the fat got torsion or twisted, then it may also lead to pain. Mesenteric infarction, this is a ischemic condition, and leaking aortic aneurysm is also causing abdominal pain. It may lead to hypovolemia. Hypovolemia can also lead to abdominal pain because of ischemia. So all these things are considered. Now let's move on to the another part of this topic, and that is diagnosis. Okay, how to confirm the diagnosis. So to confirm the diagnosis, we should always consider a good history taking, that is symptoms, sign, that is physical examination, never forget them, followed by investigation. The investigation can be lab investigation, okay, it can be radiological investigation, or it can be some other scoring system. So there are different scoring system which is developed regarding the certain conditions. Okay, in acute appendicitis also there is one scoring system which is known as Alvarado scoring system. So we'll talk about this now. Now, what are the lab investigation we like to order? The first is CBC. We already know leukocytosis is one of the important feature of acute appendicitis. So in 90% of the cases of acute appendicitis, the WBC count may be more than 10,000 or 11,000. In some of the lab, 10,000 is taken as the upper limit of the normal WBC count. In some other lab, 11,000 is taken. It doesn't matter much. Same thing. If we analyze, okay, there is usually left shift in case of leukocytosis. Okay, left shift in case of leukocytosis. That is predominance of the neutrophil. and among them also the immature type of neutrophils are relatively more common. Consider perforation or abscess if WBC count is very high. That means consider more serious type of infection if WBC count is very high, like abscess formation there. Another one is urine analysis. Now, the question may be coming in your mind, why urine analysis is done, in this case, because there is no, correlation with the urinary tract infection and acute appendicitis. Having said that, okay, what happens is pelvic appendix. Remember, pelvic appendix may lie on the surface of ureter. So what happens now? When appendix is inflamed, it may also causes inflammation of the wall of ureter, and then some of the pus cells and some of the RBC may leak into the urine. So this is one of the important point you have to remember. Another one, pyelonephritis should be ruled out as a differential diagnosis of appendicitis. If urine has plenty of pus cells, a patient is having high grade fever, okay, with renal angle tenderness, probably it is not a case of appendicitis, it is a case of pyelonephritis. So for these two important reasons, urine analysis is always done in a suspected case of appendicitis. Let's move on. Now, another one is a CRP or C-reactive protein. Now, this C-reactive protein is never specific. Okay, it is never specific. C-reactive protein is high in any inflammatory or infective condition. But what is the level? Okay, in serious type of infection or inflammation, the level is quite high. Okay, so that is the important point. Urine pregnancy test has to be done if a female comes with abdominal pain, especially the lower abdomen. So we are talking about iliac fossa pain here. So any female of reproductive age group after the age of menarche comes with abdominal pain, never forget to do urine pregnancy test to rule out ectopic pregnancy, because it is a very strong differential diagnosis of appendicitis. And it is quite easy also, easy type of test. Do electrolyte and renal panel test also, serum electrolytes like sodium, potassium, okay, and renal panel. What is a urea? What is a creatinine level? This test is not required in all type of cases, but it may be useful to help guide the electrolyte resuscitation prior to appendectomy. What we are talking here? Sometimes we need to take the patient quite urgently to the operation room for the removal of appendix, and we need to resuscitate the patient. If patient looks dehydrated, we need to give IV fluids. So during that time, we need to exactly know what is the situation of electrolyte as well, how kidneys are working. So better to do this investigation as well. Now, let's move on to the radiodiagnosis, a radiological investigation. So what are these? Very easy answer. These are X-ray, okay, ultrasound, and CT scan. X-ray, ultrasound, and CT scan. All three can be done. Now, let's talk about them now. Now, what is the role of abdominal X-ray in this case? See here. It is not particularly useful in most of the cases, but if we do it, it may reveal appendicolith or ficcolith in less than 15% of the cases. We may see this ficcolith, at the site of appendix in around 15% of the cases, but we can easily, avoid this investigation because we are definitely doing ultrasound or even CT scan. So abdominal X-ray may not be required all the time. Now, another one is abdominal CT with contrast. This is a very important test. Now, see here, it is very sensitive, almost around 98% sensitive, and specific also around 90%. So this is excellent, investigation for the diagnosis or confirmation of appendicitis. It is also useful in identifying several other inflammatory processes that may present similarly to appendicitis. Means, to rule out the differential diagnosis, CT scan is very important test. So what are the positive findings in case of appendicitis now? Okay, as a medical student, you should remember this. The appendix is dilated, okay, to less than 6 millimeter in diameter. Okay, it is usually less than that, but whatever amount of dilatation it has, it is really supportive. The appendicular wall is thickened because of inflammation. There is periappendicular streaking. Okay, this is all because of the involvement of the surroundings of appendix, like fat, and there is presence of appendiculith, not in every case, but maybe in less than 15% of the time. So CT scan is a very important test. These days, some of the hospitals routinely do it. Now see here, these are some of the X-ray which we have collected. Here is the ficcolith. See this white structure is the ficcolith, and this is the same site which we are talking. Now CT scan, this is the normal appendix in CT scan. Okay, this is the appendix. See this worm-like structure here, and here, okay, in acute appendicitis, this is swollen. See this, it is acutely swollen here. Okay, this is structure. Now here is the CT which is showing appendiculith and acute appendicitis. Look at this white bright structure. This is a ficcolith or appendiculith. This is quite bright, okay, and this is appendix right here. Now, what is the role of ultrasound? Ultrasound is also very commonly done in the diagnosis of appendicitis. Now, this is called graded compression ultrasonography. So, what the radiologists do? The radiologist will compress the appendix site with the probe of ultrasound, and ask the patient, do you feel pain now or not? Or he may look at the face of the patient where there is any grimace or not. The sensitivity of this test is around 85%, and specificity of this test is around 92% for the diagnosis of appendicitis. So this is quite a good test. Regarding the finding, appendix is enlarged, usually more than 6 millimeter, and it becomes non-compressible because of edema and swelling. Okay, because of distension, it becomes non-compressible, and when the radiologist presses there, the patient complains of severe pain. It is also very useful to rule out other differential diagnoses, especially in case of female. In female, remember, there is a problem of PID, ectopic pregnancy, ovarian pathology. So many different things are there. So better to rule out those pathology and make sure this is a case of appendicitis, and this is held by ultrasound. So one important point here which we should notice, the appendix will become compressible after perforation is a source of false negative result. Now why it is compressible? Once again, because whatever amount of content is present inside that appendix now leaked out. Okay, it is leaking out now. So again, okay, it can be compressible. So this is a false negative result. But during that time, the condition of the patient is a bit sick, a bit worse than before. So this is the way we rule it out. Let's move on now. Now, I've already talked about this. After doing this diagnostic test, some of the scoring system has been devised, which really helps in the diagnosis of appendicitis as well as regarding the management part. So one of the scoring system which they developed is called Alvarado score. So let's talk about it. This Alvarado score is a clinical scoring system used in the diagnosis of appendicitis. This score has 6 clinical items and 2 lab measurements, and the total point is 10 points here. Now, how we got the 10 points. And what are these lab and clinical scores? Okay, so let's talk about it. See this? The first is abdominal pain that migrate to the right iliac fossa. So a good history has to be taken, and the history tells us in the beginning there is periumbilical pain. After a few hours, there is a migration of pain to the right iliac fossa. Now you already got 1 point from the history. Second, anorexia. Okay. This is also done by the history taking. Anorexia means loss of appetite. Or if the patient has not eaten, food for a few days, there may also be ketones in the urine. Now, why ketone body are formed if you do not eat something for a longer time? Why?
Fats, because of fat burning.
Due to fat metabolisms.
Sir, due to anaerobic
Because in fasting state,
metabolism
ketones body breakdown.
and carbohydrates metabolism lead to the ketone formation.
Okay, very good. So, so the points are there. Most of the students have that concept already. Excellent. Though we have not talked the class of diabetes and things like that, but still, you have the concept. If somebody is fasting, okay, not eating, food for a relatively longer time, even after 24 hours, the process will start. They say, like, if you do not take carbohydrate, our body needs energy, and that energy comes from the metabolism of fat. Metabolism of fat, okay, can lead to synthesis of ketone body. Very easy answer. Okay, don't make it complicated. If there is no presence of carbohydrate, insulin, okay, will not be secreted. There's no need of insulin now. There's no carbohydrate. Why insulin should come out? So to give energy to the body, fat metabolism will occur, and that fat will form the ketone. So that ketone may be present in the urine. Okay, but usually we don't go for it. I'm just explaining the mechanism here. Another is nausea or vomiting. This is also done by the history taking. Fourth is tenderness in the right iliac fossa. This is the physical sign, one of the very important physical sign in the patient. We always, elicit this. Fifth is a rebound tenderness. 6, fever of 37.3 degrees centigrade or more. Okay, probably this is measured, okay, by axillary route. Just put a thermometer in the axilla, because fever is usually, described, or the description of the fever is more than 38 degrees centigrade. Okay, the core body temperature should be more than 38. But if we measure the temperature in the axilla, it should be 1 degree centigrade less. 7 is leukocytosis, that is more than or equal to 10,000, and neutrophilia, that is shift to the left, we say. So these are the 8 clinical criteria of the Alvarado score system. And remember, this 4th and 7th are highlighted there because these have got 2 points. Because these are very important ones. Tenderness in the right iliac fossa has got 2 points. Leukocytosis equal or more than 10,000 has got 2 points. All other got 1 point. So the total score is 10. Let's move on. Now, how to interpret, isn't it? That's another important part of this Alvarado score. We know what is the total score, that is 10, but how to interpret it. The 2 most important factors are the tenderness in right iliac fossa, right lower quadrant, and leukocytosis. That's why they are assigned 2 points. And other, 6 factors are assigned 1 point. So the total score is 10. Now, how to interpret it? See this. A score of 5 or 6 out of 10 is compatible with the diagnosis of acute appendicitis. Now, compatible, you are still a bit in doubt, it may be something else. A score of 7 or 8, a probable appendicitis, your diagnostic, accuracy or diagnostic chances are higher now. And a score of 9 or 10 is a very probable acute appendicitis. So we are almost certain, yes, this is a case of appendicitis. So this is the, interpretation of Alvarado score. So better to remember this. Now, how to remember? There is a very popular mnemonic here. Okay. This mnemonic is called Mantrels. You see this? If we remember the first letter of these different features, then Mantrels will be there. M stands for migration to the right iliac fossa, that is pain. In the beginning, periumbilical pain, later on, right iliac fossa. So this is a migration. A for anorexia, N for nausea and vomiting, T for tenderness in the right iliac fossa. Remember, this has got 2 points, very important one. Rebound tenderness. E for elevated temperature or fever. L, leukocytosis, another important feature, got 2 points. And then shift of neutrophil to the left, also known as left to shift. Okay, shift to left means neutrophilia. Especially the immature types are more commonly present there. So this is called Mantrels. Now there are some fallacy of Alvarado score also. Some of the surgeons believe, okay, this is not that very sensitive for the diagnosis of appendicitis. Some other argue, no, this is a very helpful score for the confirmation of the diagnosis. Okay. Nevertheless, in our routine clinical practice, it is desirable to score a case of appendicitis in the form of Alvarado score and see, okay, how does it go with the confirmation of the diagnosis. Now see this, make it very easy here. It helps us in the management of the patient. How it is helping in the management? Let's calculate this score, and if the total score comes 1 to 4, we discharge the patient. Probably this is not a case of appendicitis, something else, maybe a vague type of abdominal pain, and patient may not be admitted. 5 to 6, we admit the patient in the hospital and observe. We do not immediately open the abdomen and remove the appendix because our diagnosis is still in doubt. And if it is 7 to 10, we highly presume, yes, this may be a case of appendicitis, better to remove the appendix before it is too late. So this is the usefulness of Alvarado score. And these are the see this predicted number of patients with appendicitis with each of the score. Alvarado score 1 to 4, the chances only 30. Score of 5 to 6, the chances of 66%. And Alvarado score of 7 to 10, the chance of appendicitis is 93%. So if it is more than 7, it is highly likely that this is a case of appendicitis. Okay, now we are moving towards the management part, but before I go to the management, everything is summarized in this slide, so you can go through this on your own. Remember, for the diagnosis of appendicitis, I need to take a good history, I need to examine the patient well, I need help of some of the investigation also. Now, how we treat the patient. This patient has to be resuscitated first. Who knows, patient has vomited a lot, patient has not eaten food for a longer time or has not taken a drink for a longer time. So resuscitation is very important. That is done preoperatively. We have to give good amount of IV fluid and we have to start antibiotics. Now these antibiotics are very important here because this is a case of infection. Okay, this is a case of mixed type of infection. Now, what antibiotic you give in a mixed type of infection? Which antibiotic?
Ceftriaxone and cephalosporin third generation and aminoglycosides.
Good. And to cover the anaerobe, what you do? Which antibiotic?
Metronidazole.
Metronidazole. Very good. Absolutely. So you already gave me the answer. So if this type of cases comes to us, especially there is a mixture of organism there. Like some organism may be gram negative, some may be gram positive, some may be anaerobes. So better to give one very powerful group of drug like third generation cephalosporin, ceftriaxone is wonderful there. Along with that, don't forget to give either clindamycin or metronidazole to cover the NRO. Okay, patient will feel very well within 48 hours. Now, prompt appendectomy is essential here. Once you confirm the diagnosis, once you strongly believe this is a case of appendicitis, why to wait? That is the question. Why to wait? Take the patient to the operation room, open the abdomen, and remove the appendix. Sometimes you may be wrong. Appendix may not be inflamed. But don't worry. This appendix is considered as a vestigial organ. So once the abdomen is open, even if the appendix is not inflamed, you will still remove it. You will still remove it because you believe this patient may get appendix later on in life. So we have to take that chance. If it is already perforated, now the treatment is a complicated one. Okay, what should we do now? The material has been leaked into the peritoneal cavity. So we have to remove it by doing proper peritoneal washout. This takes a bit of time. And after that, we have to give powerful parenteral antibiotics to treat the case. And then, of course, we remove the appendix, whatever is left behind there. So these are the important headings. Okay, so let's go and analyze them now. Regarding the medical therapy of appendicitis, these days, okay, there are different researches has been done. Now, one of the research or one of the meta-analysis tells us, though appendectomy is still the standard treatment of appendicitis, a meta-analysis by Wilms et al. Led to the conclusion that antibiotic treatment alone might be feasible in specific patient or condition in which surgery is contraindicated. Now, for that, I need to diagnose this in time. This is the paramount important point. And quickly, I need to start the parenteral antibiotics, a good antibiotic. Patient may get well only because of this. That is the point what they are talking about. But if it is late, okay, only medical therapy may not help the patient. Sometimes patient refuse the surgery. What should we do? Sometimes surgery is contraindicated. Patient may be, having hypertension, uncontrolled hypertension. Patient may be having bronchial asthma or COPD. Patient is very old, or patient may be having uncontrolled diabetes. During that time, surgery cannot be done. So what is the next option for us? Medical therapy. These findings suggest that broad spectrum IV antibiotics should be initiated, okay, and patients should be admitted in the hospital and monitored for the progress. And usually patient will be better. Now, another type of treatment is surgery, that is known as appendectomy or appendicectomy. Okay, both terms are correct, whatever you want to say, appendectomy or appendicectomy. So this is a standard type of therapy. There's no doubt about it. And all over the world, still many surgeons believe whenever you suspect appendicitis, appendectomy has to be done as early as possible. See there? Patients with a classical history and physical examination finding, along with a normal urine analysis and elevated white blood cell count with a left shift, usually do not need any additional imaging study prior to appendectomy. Okay. This is a very good description. And you as a emergency, physician, you can easily diagnose appendicitis because of these points. A classical history, pain starts from the periumbilical region, migrated to the right iliac fossa. Physical examination, tenderness with rebound tenderness are present. Robsing sign is there. Okay, you have done the urine analysis, it is normal. You have done the CBC, it shows increased WBC count with neutrophilia. What else you need? This is a case of appendicitis. take the patient to the operation room and open the abdomen. That is the point. Surgery is also indicated in patient with an atypical presentation and radiographic findings consistent with appendicitis. Atypical presentation means the typical thing which we are talking right now may not be present. Sometimes the pain is a bit higher. Okay, sometimes the pain is atypical, not matching with the classical description of appendicitis. During that time, better to confirm with the help of radiographic evidence. Do CT scan, do ultrasound, okay, confirm it, then only operate the case. Let's move on. Now, how to prepare for surgery. This is a very important knowledge for a younger doctor. Most of you, after you graduate from the medical school, will join some hospital and start working in the emergency department, okay, accident and emergency department. And if the case like this comes there, it is your job to prepare the patient before you inform the surgeon. So how to prepare the patient? See here, all patients who are diagnosed with appendicitis, okay, should be adequately hydrated with isotonic IV fluids. These isotonic IV fluids are normal saline or lactated ringer. Lactated ringer is preferred. In addition, broad spectrum IV antibiotic, see that, ampicillin, gentamicin, or metronidazole, or a third generation cephalosporin and metronidazole. Whatever combination you want to use, it's up to you. Why? The question comes here. Ampicillin is covering gram-positive organism. Gentamicin is covering gram-negative. Metronidazole is covering anaerobe. This is one of the good combination. If you don't want to use so many, then straight away go for ceftriaxone or and metronidazole, not or, okay, and metronidazole. The ceftriaxone cover both gram-positive as well as gram-negative. So that is the point here. It should be started prior to the operation, after you have diagnosed it. Antibiotic, analgesics, and antipyretic should not be administered to the patient admitted for serial examination, because this medication may mask the underlying disease process. Now, you may not agree with this statement. Some of the students even have not understood what is the meaning here. So please listen properly. You are a young doctor there. You are, an immature doctor. You have not seen this type of cases before. You don't know, is this a case of appendicitis or not? You are waiting for your consultant to come. So before the consultant comes, do not give analgesic, do not give antipyretic, and even if possible, if patient is not that sick, do not also give antibiotic, because it will hamper those physical signs. When your consultant comes and try to examine, these physical signs should be present there. If they're absent because of these drugs, diagnosis is in doubt and patient may suffer. But having said that, if the patient looks very sick, if patient is already having features of peritonitis, patient is in shock or sepsis, I have to give antibiotic as soon as possible. Okay, there are some other way for the diagnosis also. Let's move on. Now, this is the McBurney's point. Okay, you have already seen. So we have to find it out by examination, and probably we have to give incision right through this area. Now, see this? This is one of the picture which is showing appendicectomy or appendectomy surgery. So what they are catching it? See this? This is appendix, isn't it? This is appendix. It looks like quite a long appendix in this case. The base is also caught here, okay, and probably they have already cut the appendicular artery and they are about to ligate it. Okay, so beautiful picture which is showing appendectomy. This is the site where appendix is present in our body, that is right iliac fossa, and this is the way surgery is done. Sometimes surgery can be done with the help of laparoscope also. This is known as laparoscopic appendectomy. Now, you may be wondering when we go for laparoscopic appendectomy. My answer is in the early cases of appendicitis, before it is ruptured, okay, laparoscopic appendectomy is the best. After the appendix gets ruptured, we need to open the abdomen, we need to wash out the peritoneal cavity. So this is not a good way of doing surgery. Now, see there, so these are the different surgical tools, okay, in case of laparoscopic appendectomy. And these are the different incision which we give for appendectomy, different incision, okay. Now, usually which incision is given, you can see here, that is McBurney's incision. The number 4 is most commonly given for appendectomy. But sometimes if the case is, very complicated, like peritonitis has already occurred, we can go for paramedian incision or even midline incision, because we want broad field of vision, okay. So they are in complicated cases. So there are certain other incisions shown which are not used for appendicitis here, like the subcostal. Can you guess where the subcostal incision is given for which condition? Just see there, this number 1 for which condition? Anyone?
Liver disease. Liver disease.
Okay, good. Rather than liver, it's for gallbladder. Okay, gallbladder.
Or removing gallbladder.
Exactly. But he's right. I cannot, ignore his answer, because that liver is right there. But is usually in the field of surgery, gallbladder disease is so common, like cholecystitis or cholelithiasis. We want to give the subcostal incision during that time. Now, can you guess this number 5 is given for which condition? The incision number 5?
Bladder and stone.
Okay.
In female C-section, sir.
C-section.
In female C-section.
C-section.
Exactly, C-section. We have done this. Okay, in C-section, this is called Fanon steel incision. Okay, this is done for lower segment cesarean section. Don't forget this name. This is acts as an MCQ question sometimes in the exam. This number 6 can be used for any intestinal lesion. Now, this is how the scar looks like. This is a McBurney's incision, and this is a healed, scar. Later on, it looks like this. This is a proposed algorithm for the management of acute appendicitis. Okay, you can see this on your own later on, because the concept you already got. In the beginning, we have to assess the patient, whether this is a case of appendicitis or not. We have to resuscitate the patient. If patient is unstable, means patient looks sick, the vital signs are not in the normal state. You need to resuscitate the patient, give IV fluid, okay, bring the vital sign back to the normal, do CT if the diagnosis is still in doubt, and after that take the patient to the operation theater for the surgery. In case of a stable patient where vital signs are within normal limit, in case of male, we do like this. In case of female, there is a high chance of gynecological pathology, so we do or follow this type of algorithm. Okay, it is very easy for us to understand. Now, let's move on. Another part of this lecture is complication. What complication can happen in a case of appendicitis? The overall morbidity of appendicitis is approximately 10%. Okay, 10% chance of morbidity. So, patient may get sick for a different reason here. Most perioperative morbidity is caused by infectious complication, like wound infection, absolutely common in a after the case of appendectomy. Wound infection, very, very common, because that site is infected already. Appendicitis means already infected there. Sometimes the pus may leak outside, and if that pus, okay, contaminate our incision site, there is high chance of wound infection. So it occurs in approximately 5% of all appendectomy cases. Okay, let me highlight this. 5% of all appendectomy cases, there may be chance of wound infection. However, the incidence of this complication is related to the stage of appendicitis. The wound infection rate is 1.4% for non-acute appendicitis, 3% for acute appendicitis, and 10 to 15% for perforated or gangrenous appendicitis. So it all depends on how much pus is present there. Okay, what is the proliferation of microorganism there? It all depends on the condition. If it is a complicated situation already, there is a higher chance of wound infection. Let's move on. Now, another complication is the formation of intra-abdominal or pelvic abscess. Now, this is a serious complication here. Formation of intra-abdominal or pelvic abscess after we do appendectomy. It occurs in around 2 to 5% of the patient. The incidence is again higher for gangrenous or perforated appendicitis than for early or suppurative appendicitis. So the late case will have more chances. Other complications include persistent ileus, small bowel obstruction, and pulmonary complication like atelectasis and pneumonia. Now, what is ileus? What do you mean by ileus?
So it's a colicky pain, and also it's a paralysis.
It is a paralytic ileal which is caused by the hypokalemia.
Good, good. Yeah, already answered me. Very good. This is a case of paralysis or immotility of the bowel. Paralysis or immotility of the bowel. In this case, it is because of inflammation, okay, and because of handling of the bowel during surgery. Because during surgery, you know, we handle the bowel, and when we touch the bowel will develop paralytic ileus-like state. Okay, and Adnan is answering, you know, hypokalemia. Yes, hypokalemia is one of the important cause of paralytic ileus, but to develop hypokalemia in a case of appendicitis, the patient has to vomit a lot and for a longer time. So probably that may not be the common cause. It is because of the handling, excessive handling of the bowel, and because of peritonitis or excessive inflammation. Okay, this small bowel obstruction can occur because of adhesion, which is quite common after surgery. After you open the abdomen, after you open the peritoneal cavity, there may be scar formation, adhesion formation, and that may cause obstruction later on. Pulmonary complication is quite common, especially in the older population. Because of the pain, they cannot cough much. The secretion in the respiratory tract will accumulate there, and that can lead to collapse of the lung, which is known as atelectasis, and pneumonia as well. Apart from them, DVT, see this, deep vein thrombosis because of immobilization, pulmonary embolism after DVT, and even myocardial infarction may also occur in the early postoperative period. All of these are associated with thrombosis. Now, let's talk about one of the very important part of this lecture, that is appendiceal mass or abscess. A small short note or short question can be asked from here. Now, why the appendiceal mass or abscess forms? That's our number one question. How to diagnose and how to handle the situation, or how to do the management. The appendiceal mass is the end result of a walled off appendiceal perforation, and it represents a pathological spectrum ranging from phlegmon to the abscess. Phlegmon to the abscess. Now, this phlegmon may be a new term for you. Okay, meaning is very simple though. This is the involvement of soft tissue which are around the appendix. If those soft tissues are inflamed, okay, we call them phlegmon. Abscess is a localized collection of the pus. Now, what we are talking here, please listen properly. Appendix is inflamed. Now, what is the natural tendency of our body, okay, to restrict that inflammation in the appendix? I have told this, reason before also. The greater omentum is known as policeman of the abdomen. This greater omentum will wrap this inflamed appendix and doesn't allow the infection or inflammation to go outside. Remember this, okay? It doesn't allow the infection or inflammation to go outside. On that process or during that process, it will form a mass. This is known as appendicular mass. But sometimes, okay, the infection or inflammation is so much that abscess can form very easily. So it also contributes in the mass formation. So it is a common surgical entity encountered in 2 to 6% of patients presenting with acute appendicitis. Now, what are the signs and symptoms? They are similar to acute appendicitis. Okay, all the signs and symptoms, whatever we have discussed till now, are present here also. There is increasing left lower quadrant pain, especially in case of abscess, the pain getting more and more. The site is tender. It is fluctuant right lower quadrant mass that is palpable even on rectal examination. Okay, we can feel it by per-rectal examination also. Patient may be having high-grade fever, especially in case of abscess, but in case of appendicular mass, the fever may not be high. Okay, anorexia is also there. Anorexia, there is localizing peritonitis, and there is leukocytosis as well. Now, how to confirm the diagnosis? One is physical examination. We always do that, and it is confirmed by ultrasound, or if facility is available, directly go for CT scan. Let's move on. Now, how to manage it? Isn't it? That's a important question to answer now. Now, listen here. There are different type of concept here. Some of the surgeons say our body has already trying to contain the infection in the appendix by wrapping it up with the help of greater omentum. Why to disturb that? Why to disturb that at this moment? Okay, some surgeons argue like that. That's why they say we have to wait for 6 weeks for everything to settle down and then go for interval appendectomy after 6 weeks. This is called interval appendectomy because there is a certain interval between the presentation and the surgery. Some other believe this is the right time. Patient has come to us. We have to utilize this moment, this situation, and go for the surgery to avoid some unwanted complication later on. So different, spectrum of the management may be there or may be mentioned in the textbook. So let's analyze this in a bit detail here. Appendectomy remains the only curative treatment of appendicitis. There's no doubt about it. But management of the patient with an appendicular mass can usually be divided into following 3 treatment categories. So what are these? First, patient with a phlegmon, and the phlegmon is a localized area of acute inflammation of the soft tissue or a small abscess only. So what we need to do now, after intravenous antibiotic, an interval appendectomy can be performed 4 to 6 weeks later. Okay, so this is the appropriate step in this case. Patient with a larger, well-defined abscess. Now, abscess is big. Patient may be febrile. Okay, high-grade fever may be there. Patient may look more sick. What should we do? After percutaneous drainage, okay, of the pus or abscess, we give IV antibiotic. And patient can be discharged with the catheter in place. We don't do anything for the appendectomy. We just have drained the pus, remember that, and we have given antibiotic. Again, interval appendectomy can be performed after the fistula is closed. Okay. This fistula is a doctor-made fistula, isn't it? It's not a natural or a pathological type of fistula there. So it is closed first, and then interval appendectomy is done after 6 weeks. Now my question, why not appendectomy is done right there when there is abscess formation? Anybody? Why?
Sir, there is chances of appendicular pyemia.
Because there is spreading of the abscess, sir, causing even more further sort of infection, sir, most probably.
So that plus can spread to the localized tissue and
Yes,
can cause
sir.
complication.
Spread of the so spread of abscess content mainly.
Yeah, your answer is almost there. Very good. So remember, this is a surgical principle. Wherever there is a severe infection going on, okay, especially like abscess condition, we treat the abscess first, okay, but you don't want to cut that area or you don't want to put suture there. Number one, those soft tissues, okay, will not hold the suture because they are very friable, and you are helping the infection to further increase if you do this type of things. And one more thing, okay, you have already mentioned, the infection may enter easily into the bloodstream, resulting in pyemia. So in case of active type of infection at that site, as far as possible, okay, do not go for surgery. You give time for that inflammation or infection to settle. Use antibiotic, and later on you definitely go for surgery. Now the third situation here, patient with a multi-compartmental abscess, what should we do? This patient require early surgical drainage because there are many compartments. We need to break those compartments and make that into a single abscess cavity, drain that, and again you can go for interval appendectomy later on. Now we are coming towards the end of this topic. What should we do if a pregnant lady develops appendicitis? Now, first of all, in case of pregnancy, the diagnosis of appendicitis is a real challenge. Okay, it's a real challenge. The reason is there. Why? Because when the uterus is enlarged, okay, it pushes everything up. It pushes or displaces everything upwards. So the appendix is also present right up into the right upper quadrant now. Usually it is present in the right lower quadrant, but in case of pregnancy, it is present in the right upper quadrant. So it almost present like a case of cholecystitis, but actually this is a case of appendicitis. So the diagnosis itself is a challenge, but high index of suspicion has to be there. Then only you can diagnose it. Fetal mortality increases 3 to 8% with appendicitis and 30% with perforation in case of pregnancy, and surgery is the standard treatment there. Okay, but because of the surgery and appendicitis, around 10 to 15% of the women will experience premature labor. Now, what we do in the elderly patient? Elderly patient means, for example, later than 75 or 80-year-old. They also tend to present atypically, leading to delayed diagnosis. They are relatively immunocompromised population, so the features of inflammation may not be that much. Okay, so those typical signs and symptoms may not be present. So that is the point. So see that they present later in the course and with less pain, and they may present as a small bowel obstruction, which is not a very common presentation in appendicitis. There may be delayed leukocytosis, not early, and there may be a higher risk of perforation and higher mortality because of delayed diagnosis. There is no other reason for that. What about in immunocompromised patient like AIDS or recipients, okay, of high dose chemotherapy after organ transplantation? Similar to the very old population. They are immunocompromised, so the signs of inflammation may not be that much. Okay, the absolute type of leukocytosis may not be that much, so the high index of suspicion is again required. Otherwise, they may present with perforation and complication quite early. Now I am towards the end of this important topic called appendix. At the end, I have also included some of the neoplasm which occurs in the appendix. And one of the commonest type of neoplasm or tumor which develops in the appendix is called carcinoid. Okay, carcinoid. You have already heard this term before. This carcinoid is a type of neuroendocrine tumor. Okay, neuroendocrine tumor. It secretes enzymes and the hormone. Enzymes and the hormone. Now, which substance is secreted by this carcinoid? Which substance is that? Anyone? Anybody? Which hormone? This
Sir, can
is,
you repeat the question? I couldn't hear it, sir.
yeah, this carcinoid is secreting which substance? And as a result of that substance, these clinical features are present. Which substance is that?
Sir, it release histamine. That's why it lead to the nausea,
Serotonin.
diarrhea, and flushing.
Okay.
Sir, serotonin.
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 Okay. So now see, listen. Remember.
Serotocoids.
Okay. Now remember, when we talked about the pathology of the heart, okay, in the pathology lecture, during that time we talked about a bit about this carcinoid. This neuroendocrine tumor called carcinoid produces serotonin, and this serotonin is responsible for most of the clinical feature in case of carcinoid. Now listen properly here. This tumor is very small in size in the appendix, but it can metastasize quite early in the liver. When it reaches the liver, it can grow quite fast and it produces large amount of serotonin. This serotonin will, okay, mix into the blood. It will travel into the different parts of the body and different clinical features are produced like nausea, vomiting, diarrhea, cutaneous flushing, okay, and in the heart, it can lead to narrowing of the valve because of overproliferation. Now, how to diagnose it? You have to prove there is excessive serotonin or there is excessive metabolite of serotonin in the urine. That is 5-hydroxyindole acetic acid. Okay, 5-hydroxyindole acetic acid is excessively present in the urine. So this is how we diagnose carcinoid, and at the same time you can also go for some radiological test which will prove metastasis to the liver. Now regarding the treatment of carcinoid, okay, now see this, the size is the major determinant of treatment and malignant potential of this carcinoid. If the tumors are less than 2 centimeters, they are treated with only appendectomy. When we remove the appendix, the tumor is also removed. This is the surgical management. Tumors more than 2 centimeters are treated with right hemicolectomy. Now this is a big surgery. Now, can anybody tell me what is right hemicolectomy? What do you mean by that? Yes? What are the parts of colon? Tell me that first. What are the parts of the colon?
Ascending colon, transverse colon, descending colon, sigmoid.
Sigmoid colon.
The cecum ascending colon,
Colon.
descending colon, the sigmoid colon.
Transverse colon, descending colon. And
Colectomy is removal of colon.
Exactly. So the parts of the colon are cecum, okay, cecum, ascending colon, transverse colon, descending colon, and the sigmoid colon. Rectum is also part of that. So which of them are present on the right side? Now, if we concentrate, appendix is also part of the colon. Remember that appendix, cecum, ascending colon, and right half of the transverse colon. These are called, okay, colon present on the right side. If we remove them, it is known as right hemicolectomy. Right hemicolectomy. This is the meaning. We need to use some serotonin antagonist, okay, like cyproheptadine or somatostatin analog like octreotide. They can be used for the symptoms of carcinoid syndrome or to control them. The cyproheptadine is considered as an antihistamine drug also, but it can act as a serotonin antagonist as well. Now, this is the last slide for today. Okay, sometimes there may be some mucinous tumor which may develop in the appendix. A mucinous tumor means they produce large amount of mucin, okay, sticky type of substance. And if they rupture, okay, if they rupture, that mucinous material may leak into the peritoneal cavity, and this condition is known as pseudomyxoma peritonei. Pseudomyxoma peritonei. This can be asked as an important question in the MCQ exam. This is not the only condition which can lead to pseudomyxoma peritonei. Sometimes ovarian tumor can also lead to this situation, because there are different types of ovarian tumor. One of the ovarian tumor may be mucinous cyst adenoma. If that mucinous cyst adenoma also rupture, then similar type of condition will be developed. It is more common in female in the ratio of 3:2. Complications include bowel obstruction and perforation. In the beginning, definitely there will be bowel obstruction, and later on, if that is not handled in time, it can also lead to perforation, and it has been associated with migratory thrombophlebitis, which is known as Trousseau syndrome. Trousseau syndrome. Now, this Trousseau syndrome is also quite commonly seen in pancreatic carcinoma. I'll talk about that later on in the topic of pancreas. So what does that mean? Okay. One day, one superficial vein is inflamed, okay, that may get better, and the next day, another superficial vein may be involved. Migratory thrombophlebitis, Trousseau syndrome. Okay, so these are some of the important points regarding mucinous tumor. So with this, let me end this class here. Thank you very much. Okay, I'll stop here now.